I would start typing. Yeah. So I was like, this is such a good time.
All right. So when we left off last time, we were talking about our lung volumes and lung capacities, and we had introduced our ideas of obstructive and restrictive pulmonary diseases. So I got a review question real quick about one of our lung capacities that we would like to be able to identify. Get our juices flowing. And then we'll talk about those diseases again. All right, take another couple seconds to put in your selection. I'll get moving. All right. Okay. So when we were talking about our lung volumes and lung capacities, we had our non-overlapping lung volumes and our capacities. We add together different of those lung volumes. So yes, inspiratory capacity is everything you can breathe in. So a normal breath is going to be your tidal volume. And then the extra you could breathe in on top of that with a deeper breath is our inspiratory reserve volume. In total gives us our inspiratory capacity. Okay. So to understand our obstructive pulmonary diseases versus our restrictive pulmonary diseases, we're thinking about both the cause, so obstructive pulmonary diseases associated with increases in resistance, restrictive pulmonary diseases associated with decreases in compliance. And we're also going to see that this has impacts on those different capacities. So in our obstructive pulmonary diseases, we're going to see that our functional residual capacity is going to increase while our vital capacity decreases. And in our restrictive pulmonary diseases, our vital capacity, again, so like all the air we can move, is also decreasing. But instead of having an effect on our functional residual capacity, we're also going to see an effect of the restrictive pulmonary disease on our total lung capacity. So I'm going to pull up our picture of the volumes and capacities just to kind of peek in and think about why that is. Okay, so what we're saying when we talk about those, this is just that same picture from back in the previous slides, right? So we're saying our obstructive diseases, the ones that are associated with increases in resistance, are going to result in an increase in this functional residual capacity and a decrease in our vital capacity, right? So what's happening here? Okay, so our functional residual capacity is the reserve volume, that residual volume at the bottom here, right? Plus what we could get out with a very, very deep breath. So what's happening in an obstructive disease is you're basically having a difficulty breathing air out. So this is why this is going to increase, is that we're basically getting air stuck in the lungs. Okay, and at the same time, this is going to decrease our vital capacity as we're not expiring as much air. So we're going to end up with less air in total that we're kind of able to move. Versus in our restrictive diseases, the problem is with our compliance, right? So compliance has to do with that relationship between how much air, how much volume you can make the lungs hold, and how much pressure you're going to need to exert to create that volume change, right? So when we lower our compliance, it's basically harder to change the volume of the lung. Okay, so we see a decrease in our total lung capacity, decreasing total lung capacity, because basically we're no longer able to fully expand the lung because it's too hard. It takes too much of a difference in pressure. Our muscles can only work so hard. Our rib cage can only expand so much. Our vital capacity, the amount of air that we can in total move, is also decreasing at the same time, partially now because we can't inflate the whole thing. So the way we would test for this, our indicators of this, are going to have to do with some new measurements of the lungs. Okay. So if we do our pulmonary function tests, which we would do when we're trying to assess for these types of diseases, one thing we might measure is something called the forced vital capacity. Okay, so your forced vital capacity here, what we do is you take a maximum volume inhalation, so breathe as much in as you possibly can, and then you exhale as fast as possible. Okay. The forced vital capacity is going to be that total amount of air that you move through that entire out breath, right? So what we're measuring here is, okay, so how much air can you move in total? So that is our total volume expired, is our forced vital capacity. When we have a low forced vital capacity, this is going to be indicative of a restrictive pulmonary disease, right? Okay, so restrictive pulmonary diseases are the ones associated with lowered compliance. I'm actually going to draw on this bottom image for a second, right? So here we have that curve for our restrictive pulmonary disease. So we might measure our FVC at this point, okay, right? So what's happening here is that when you took in that maximum inhalation, right, breathed in as much as you couldn't fully expand that lung because it would have taken too much pressure on that tissue that now is a little kind of more elastic, stiffer, is pulling in more, is trying to collapse a bit more. We've had changes to that tissue structure, right? So that deep breath in didn't create as much of a volume change, didn't make that lung all that big, right? So that total amount of air that you can breathe in and then breathe all the way out is lower with this lowered compliance, this restrictive pulmonary disease. So the other thing that we might measure if we were trying to take a look at these diseases is something called the forced expiratory volume. So that's this FEV. Okay. So what's going on here is that as you're doing this pulmonary function test, you're measuring both the total amount of air that got moved, right? The forced vital capacity. But we also have this note about as fast as possible, right? The reason we would have a patient breathe as fast as possible is because for our FEV, we're going to be looking at time too. We're going to look at how long this takes. Okay. So in a normal lung, right, one that's not impacted by one of these diseases, we have an expected amount of air that we would be able to move in that first second, right? So we can see in this normal curve, you have a given forced vital capacity. Here we've got a 4-liter forced vital capacity, okay? We can see that about 80% of that air has been breathed out, right? You've pushed it out in that first second, right? So that's a normal forced expiratory volume. Okay. Now, a low forced expiratory volume is indicative of obstructive pulmonary diseases. So we can see here, okay, this lower forced expiratory volume, right? Much less than 80% here. It's actually less than 50% in this diagram, right? What's happening here, right, is with your narrowed airway, right, we're seeing impacts on resistance with these obstructive diseases, right? We're thinking blockage, right? With that narrowed airway, you've raised the resistance. So it's harder to breathe out. It's like breathing out through like a tiny little coffee straw, right? So in an obstructive disease, eventually you'd get to the full forced vital capacity that you would expect, right? Eventually you'd get up there towards normal, but you'd get there way more slowly because you're breathing through this tiny tube, right? So this drop in the forced expiratory volume in that first second is our indicator for this obstructive disease. Okay. Now we can see that that restrictive disease also has a lower forced expiratory volume in terms of like our numbers here, right? Like the drop on the graph. But because we also have a lower forced vital capacity, right? Percentage wise, that curve would look the same. So percentage of the forced vital capacity would still be potentially up around 80%. Maybe not quite that high, but we wouldn't see the same impacts on the speed of exfoliation. Our effects for compliance for those restrictive diseases is on the total amount, whereas in our obstructive diseases, it's like how long it takes you to breathe that air. So those are our two indicators, our two big markers for these two types of diseases. Another type of curve you might see as you're doing pulmonary function tests is this curve of flow rate, this expiratory flow rate, right? So what we're looking at here, right, is how many liters per second are leaving for each of these volumes of the lung, right? So we can see here, okay, right? So we can see here that in a normal lung, we're moving like 9, and it would really be 7 to 9 liters per second here. In a restrictive disease, one with lowered compliance, we'd see potentially some less, right? But both of these are going to be much higher than our obstructive pulmonary disease, where we're having this problem of getting air to physically go through that tube with its increased resistance due to a lowered radius. And you can see that this restrictive disease, right, we're not going to do any calculus, right? But if you think about that area under the curve, right, we're breathing out fairly fast here at the beginning, but we're also done breathing out much quicker, right? We're only getting to a certain total volume. While with the obstructive disease, it's taking us longer. We have a slower rate, but we're still going for a long time, right? So that's going to be a difference we might look at when we're comparing these. All right. So from this, we just really want to know those main indicators for these two types of diseases. We want to know the main causes. So for those pulmonary function tests we just went through, what would we be looking at if we're trying to tell these apart? Okay, take another couple seconds to pick those out. And let's take a look. Okay, good. All right. So an obstructive disease is one where we have high resistance, right? So high resistance. Okay. And with that high resistance, this means that our big problem is when we're breathing out, we can't do it so fast. So we expire that volume more slowly, right? So we would measure that with the lowered FEV. So that 1 second measurement is going to be less than 80%. For our restrictive diseases, the lung can't fully expand because we have low compliance, right? And the result of that lung not being able to fully expand is that our total volume, that we breathe out, that FVC, right, is going to be lower, right, because we just couldn't make that lung as big as we wanted to. Right? So these are the indicators we'd be looking at and comparing to figure out why someone's having trouble breathing, like what the problem is. So we can see those curves here again, right? So we see that obstructive disease, right? We have slow flow out, right? So we can see that low FEV. For that restrictive disease, our real problem is that total forced vital capacity is lower. So we would take both of these measurements and take them into account. Okay. So what we're going to be thinking about next is we're going to start to move our way towards thinking about actual gas exchange, first between the lungs and the blood. So we're going to be thinking about what's in the air, what we have to diffuse across, what that barrier is, what's in the blood. Then we're going to move our way and think about exchange between the blood and the tissue from the perspective of our gases. So our first stop for this is starting to think about how much air we're actually getting into the respiratory system in a certain time period. Okay, so what we're going to begin with is a concept called the minute ventilation, right? So at the minute ventilation is really just what it says on the tin, right? So in a minute, how much are you ventilating, right? So how much air is coming in, right? So to do this, we take our tidal volume. So we're assuming people are just taking normal, easy breaths, which is usually about 500 milliliters, okay? We're going to multiply that by our respiration rate. So how many breaths per minute, right? So something like 10, 11, 12, something like that. How many breaths per minute we take is going to give us our minute ventilation. Okay, so that will tell us how much total air reaches our airways, reaches our respiratory system over a period of time so that we can kind of start to compare that to some benchmarks and what we might expect. However, if we're trying to think about how well are we doing at oxygenating the body, how well are we doing at getting rid of carbon dioxide, our waste product, we might want to take into account the fact that not all that air is in the alveoli. Not all of that air is in the respiratory zone of our respiratory system. Some of that air is in the conducting zone. And the conducting zone is just our series of tubes, our series of airways that gets the air down into the lungs. We don't have actual gas exchange happening in those spaces. So we think about them as kind of anatomical dead space, right? They're there anatomically, they're part of our respiratory system anatomically. We need them to get air down into the lungs, but they're not participating in gas exchange. So if we're thinking about how much oxygen is your body getting, we wouldn't really want to count that air because that air is not going to get into your blood. So we think about them as dead space. We've got approximately 150 milliliters of it. So we're going to be thinking when we think about alveolar ventilation about what happens as we swallow in air. Okay, so we're going to start at the beginning here. So when we are breathing in a breath, right, inside the alveolus to start, right, we're going to have air that has already participated in gas exchange, right? So the air that's in the respiratory zone in the alveoli, right, participates in gas exchange. And as you breathe out, it starts to move out through your airways, okay? So we might find that air as we have breathed out in that anatomical dead space in the conducting zone, while our fresh air is going to be like out in the environment, out near our mouths, right? Okay. So next, all right. So next we're going to breathe in. All right. So we had some old air still in that conducting zone, still holding those airways open, not participating in gas exchange now. We've already sucked out all the oxygen and filled it with carbon dioxide. Now, when you breathe in, right, you're going to breathe in air from the atmosphere. You're going to breathe in air from the room. You're going to breathe in fresh air. But that old air doesn't just magically disappear. So that old kind of used up air that is still stuck in your conducting zone goes back down into the alveoli first, right? Because it's the closest column of air to the alveolus. So when we breathe in, right, when we inspire, right, we're going to end up with that dead space air in the alveolus, as well as some amount of new fresh air, right? So not all the air that we moved in to our lungs hit that respiratory zone, right? Some of that fresh air is actually still here, kind of in the conducting zone. And some of the air that we moved into the lung is old air that was hanging out in the conducting zone. So we can see actually that that amount matches, right? So this old air down here, we've got the same amount of it as that fresh air that's kind of stuck in the conducting zone here. All right. So at this point, we have gas exchange with the blood. So oxygen goes into the blood, carbon dioxide comes out of the blood. That can happen because we have that really thin respiratory barrier between our alveoli and our capillaries, right? We've just got that one layer of cells forming the edges of the alveoli. We've just got that one layer of cells forming the capillaries, and just a little thin basement membrane gluing them together. Okay, so anything that's in the respiratory zone is affected by that exchange. So it gets filled with carbon dioxide and we suck that oxygen out, right? Okay. So we can see that color change, right? So this fresh air, we've now made like that old dead air, right? So we've seen that color change. Well, that amount that was in the conducting zone, even though it was fresh air, right? It's in the conducting zone, so it can't participate in gas exchange. So it's still just there. Then when we expire, right, we can think about this column moving up as you breathe out, as that alveolus gets smaller and therefore puts higher pressure on the gas inside it, right? So that whole column shifts up, right? So this old air is going to be in the conducting zone, right? And we're going to have fresh air just outside, right? So this all gets pushed out. Some of this old air got pushed out, right? Mingles in with the fresh air. You got new fresh air in your mouth, right? But we didn't get the bottom part of this old air out. It's just in the conducting zone. Okay. So when we think about alveolar ventilation, we take this into account. If we looked at the minute ventilation, we'd just be looking at the air that we breathed in, right? We're not being specific about how much of it participates in the exchange. But we do actually care about that because that's what your cells are dealing with, right? Is the gases. So for our alveolar ventilation, we add on this little detail, right? So we have that volume of air from before. So our minute ventilation is still in this equation, right? So we've got our tidal volume, that 500 milliliters by our respiration rate. So however many breaths per minute we're taking. but we're going to subtract out how much dead space we had, right? We're going to subtract out how much air is kind of old air, or thinking about it another way, is getting stuck in that conducting zone and not participating in gas exchange. So we're going to take that dead space volume. And since we have dead space volume for each breath we take, right, we're also multiplying that by the respiration rate, right? We also want a per minute measurement here. Okay. So let's work an example. Okay. So we're going to think about a person who has a normal tidal volume of 500 milliliters. We're going to make our math easy for ourselves. So they're going to have a respiratory rate of 10 breaths per minute. And they're going to have a dead space volume of 150 milliliters, which is our normal amount. So we want to compare what their minute ventilation is going to be versus what their alveolar ventilation is going to be. I'm not going to make you do this math on the exam. There's a practice exam up now, by the way. But I do want you to understand the difference between minute ventilation and alveolar ventilation. And I find it's helpful to look through an example to kind of really register that difference. I'll give you a couple minutes to think about this. Okay, take another couple seconds and then we'll walk through how we do this. Let's take a look. We do. Okay, good. All right. So yeah, what you might notice immediately for these answer choices that I've given you, right, is that we're looking for a minute ventilation and an alveolar ventilation, right? So we might start, before we do any math on this specific problem, right, by thinking about which one should be higher and which one should be lower. right? So our minute ventilation, it's always going to be higher than our alveolar ventilation, because in our alveolar ventilation, we're subtracting away that dead space, right? So in our correct answer, we have a higher minute ventilation, lower alveolar ventilation, right? But for, yeah, I believe all of your other answers, we had a higher alveolar ventilation, and that's just never going to be true, okay? We're always going to be subtracting stuff away for that alveolar ventilation, which is going to let us account for, like, we have something going on, which is resulting in more dead air, less air that's participating in gas exchange than we might expect. Okay, so for our minute ventilation, we started with our 500 milliliters. We had a respiration rate, a respiratory rate of 10 breaths per minute. So we got 5,000 milliliters, which is 5 liters. For our alveolar ventilation, we start the same way, right? So we start by multiplying that tidal volume by our respiration rate, get 5 liters. And we subtract away that dead space volume. Oops, put that number wrong. The dead space volume by our respiration rate. And we subtract those two values to get our 3.5 liters. So we are now going to think about what's going on with those gases. We're going to start in on this, right? So we care about those because we care about how much oxygen our blood is getting, and therefore how much oxygen our tissue is getting. We care about how well we're doing at breathing out our carbon dioxide, especially because carbon dioxide acts as a biological acid in the blood and messes with our pH if we keep too much of it in there. Okay. So we can actually look at something called the oxygen cascade throughout the body. So this is a big picture thing that we'll build towards, right? But what starts out happening in the lungs, right, is that we have our lungs absorbing oxygen at about the same rate that our cells are using it, right? So we're going to be absorbing about 250 milliliters of oxygen per minute. And our cells throughout the body are going to be using about that same measurement, right? About 250 milliliters per minute of oxygen for all that metabolism that we're doing, all that ATP that we're making, right? So we're really just trying to replace that oxygen that we've used up. And the same thing is going on with our carbon dioxide, right? So we are breathing out our carbon dioxide, right, at a certain rate, okay? And that corresponds to how much carbon dioxide our tissues are producing. We're deliberately going to change how fast we breathe in order to match up these ratios, right? This isn't an accident. It's that our body is maintaining homeostasis, maintaining blood pH, maintaining these gas levels, right? So we change our cardiovascular system and our respiratory system to make sure that these match up, okay? The result is that when we look throughout the body, we're going to have some values for oxygen and carbon dioxide that we're going to expect if we look at the blood, right? We're keeping the values of oxygen and carbon dioxide the same kind of throughout our arteries, regardless of how fast we're breathing, how fast we're using oxygen and carbon dioxide at the bottom, because we're changing that respiration rate. And we can also measure something called our respiratory quotient from this by looking at the ratio of carbon dioxide that we're producing to the amount of oxygen that we're consuming, right? As we move forward eventually to our gas exchange with tissue and stuff, we're going to be taking a look at what amount of oxygen would we expect to see here in our arterial system. What amount of carbon dioxide do we expect to be going back towards our heart to get reoxygenated, drop off that carbon dioxide in the lungs, right? We're going to have numbers that we can basically predict that are all driven by this exchange happening at either end. So we're going to start out by thinking about how those gases are diffusing in the first place. Okay. So those gases have to diffuse across that respiratory membrane that we looked at before, right? So we have the type 1 alveolar cells making up the wall of the alveolus. We have a basement membrane that we can kind of think of as glue between our cells, okay? And then we have those endothelial cells forming the walls of the capillary, right? So just these 3 layers that those gases have to travel across. And they can do it because they're small nonpolar gases. This is happening passively. We don't need to use any energy for the gases to travel. The only energy we used, right, was to change the size of our chest with the muscles, right? No energy for this part. Okay. So factors that are going to affect how much oxygen we get in the blood, how much carbon dioxide we get in the blood, are going to depend on our partial pressures of our gases, which are essentially going to be like how much of the air you're breathing is oxygen, right? Like what percent? If we're thinking about the pressure of the gas in the room, what part of that pressure is the responsibility of the oxygen? And then we're also going to have to think about the properties of blood, right? We're going to have to think about the properties of plasma. It's a liquid. Gases behave differently with respect to liquids. So we're going to have to think about how soluble each of these gases is in the liquid that makes up our bloodstream. Right. So we saw the ideal gas law before. We're being a little hand wavy about it, right? But we saw that we have a kind of trade-off between pressure and volume, right? So when we expand the volume, the size of a container, the pressure goes down. If we clamp down on the volume, the size of a container, the pressure goes up. This also points out to us that the pressure of a gas is going to be dependent on the number of the gas molecules, that's our N. It's going to be dependent on the temperature, that's the T. There's a constant in there, that's the R part, right? And then we also have that volume of the container in here, that's the V, right? So if we reshape this equation to look just at the pressure, those are the things we would factor in. So when you're breathing in air, you're not breathing in pure oxygen, you're not breathing in pure carbon dioxide, right? On a normal daily basis, you're breathing in air that's a mixture of gases, okay? So we've got a mixture of different molecules forming the gas around us. What the partial pressure of a gas is we're describing that gas as being a total pressure, right? So like take our atmospheric pressure of like 760, right? We're going to say of that 760, of that total pressure, some percentage is due to how much oxygen we have. Some percentage is due to how much carbon dioxide. Some percentage is due to nitrogen. And we can just stack them up, add them all together to get that total pressure. So the partial pressure for a gas is going to be a number corresponding to the total pressure in like our room, in our environment, and related to the percentage of that gas mixture that is that specific molecule. Okay. So to calculate it, we'd just take our total pressure. So we're thinking like our atmospheric pressure for our purposes. We'd look at what percent or what fraction is that particular gas, right? Oops, sorry, I circled the wrong thing, right? But if we measure the percentage by our total, we'd get the partial pressure of the gas, right? So if you imagine multiplying atmospheric pressure, right, by the percent oxygen, you'd get the partial pressure of oxygen, which we would express like this. Partial pressure of oxygen, when we see it later, is going to be the PO2. So that's it. It's really just a percentage of that total. So it happens to be the case that the air around you is about 21% oxygen. It's about 79% nitrogen. It's got a little bit of various other gases, including carbon dioxide, which we care about, helium, argon, other stuff, right? It's there. And depending on how humid your environment is, water can make up a lot of that too. Water vapor is a gas as well. So if we wanted to calculate out the partial pressure of our gases, right, here we have some worked examples for us, right? So to do it, we'll start with nitrogen, right? So for our partial pressure of nitrogen, okay, we take that 79% of the air is made of nitrogen, right? So that's our percentage nitrogen. We just multiply it by our atmospheric pressure of 760, okay? And we'd get 600 millimeters of mercury as our partial pressure of nitrogen. We can do the same thing for the oxygen, right? So we are again just taking a percentage, right? So we're got that total pressure, that atmospheric pressure of 760. Oxygen is 21% of the air. So 21% of 760, we get 160 millimeters of mercury as our partial pressure of oxygen. So air happens to be very little carbon dioxide. We've only got 0.03 carbon dioxide in the air around us. In the lung itself, that's going to be a little different because we have to take into account, right, like that dead air, right? We just talked about alveolar ventilation. We've got dead air that we've put a bunch of carbon dioxide into, right? So in the air surrounding us, we have a really low amount of carbon dioxide, but we're going to have a little more when we look inside the lung. Okay. The other thing that is happening is that as you're breathing in, one of the jobs of your conducting system is to humidify the air, right? So it's like nice and warm. It doesn't dry out the inside of your alveoli. We know there's water in there. We know there's surfactant in there, right? We want that air to be kind of warm and wet. Okay. And it happens to be the case that the composition of the air is changing at 100% humidity because water vapor is a gas. Okay. So if we were to calculate these out at that 100% humidity, we wouldn't just take into account our nitrogen and our oxygen, right? We'd also have to take into account our water vapor, right? So percentage-wise, the components of this air are going to be changing, right? So we're no longer going to have exactly 79% nitrogen, exactly 21% oxygen, because we've added in some water vapor. So we're not going to calculate them out here exactly, but you'll see that our numbers have dropped, right? So this partial pressure for nitrogen is now a bit lower. That partial pressure for oxygen, also a bit lower than what we calculated on the previous slide. And we now need to take into account a partial pressure for our water vapor. Okay. And since we're going to be thinking about carbon dioxide, at this point we do have a very small partial pressure for our carbon dioxide. Now, as we start to think about what this means for our bodies, for our blood, we need to think about the fact that gas can exist in gas form, but it can also be dissolved in a liquid. And the ability for that gas to get into liquid depends on what specific gas it is and also the properties of that liquid itself. Okay. You have a partial pressure, whether we're talking about a gas in the air around you or whether you're thinking about the gas in the blood. And those partial pressures are going to affect each other. So the partial pressure of that gas in the air is going to affect how much gas gets into the solution. So how much gas gets into the liquid. But conveniently, right, we're going to find that the blood next to your lung moving slowly enough in those capillaries, right? This is going to be my alveolus, right? We've got movement back and forth, right? And we've got enough time for those partial pressures to come to equilibrium. So they wouldn't be the same amount necessarily in terms of like the number of moles of the gas, but they will come to the same partial pressure. So like our partial pressure of oxygen in the alveoli, right, is going to come to equilibrium. So it's going to equal the same amount as our partial pressure of oxygen in the blood. And same thing for our carbon dioxide. Okay, those are going to come to equilibrium with each other. Okay, and we'll talk about the details of this next. That's our setup.